Thank you for that great presentation, Ian. We are now joined on the panel. Are we able to see?
Yep.
Hi.
Weird watching yourself.
Yeah. Hi, I'm Emma, by the way, and I've got Dan here as well with me.
Hi. Hi, Daz.
Hi.
Thank you so much for both of your presentations. Extremely valuable, particularly for students, from a student perspective. I guess I'll kick off the questions with Darshini. As a student, in my experience, I feel as though quantitative research we get a lot of exposure and a lot of experience with it, but not so much qualitative research. Why do you think that is as a student?
As a student, I think that question really should come to people who are designing our curriculums, but I think it's absolutely true. And I think that, particularly in faculties of medicine, that the emphasis is on working out what works and understanding risk and understanding, those types of questions. And so traditionally, there has been an emphasis on quantitative research. I think when I've reviewed the med degree, the health science degree, our current Masters of Public Health at Monash doesn't even have a qualitative subject. I guess lecture into different units, but it's definitely not a focus. I do think it is changing because there are big public health and health service research questions that can't be answered, but it does mean that you do end up having honours students, PhD students who haven't been exposed to qualitative research as a concept, as a theory, prior to commencing their studies. And you're very reliant then on having very strong supervisors who know what they're doing to help guide you in that.
I guess a follow-on from that is a question from Penny. She's asked, as a qualitative researcher, how can we make sure that we are building the profile of qualitative research so that one day in the future we can experience less of the same 10 questions or pushback from researchers who may be trying to understand research from a quant paradigm?
Yeah, a good question, Penny. I think there's a lot of education still to be done, and one of the things that we need to clearly communicate is that they are two different research paradigms. So some of the quality metrics that we have for quantitative research, we can't apply, or it's not suitable to put or impose on qualitative research. The BMJ came out a couple of years ago and said they weren't going to publish qualitative research, and there was a massive pushback in the research community. And so there was a big advocacy swell to have all these researchers write in and talk about the value of qualitative research. And that's increasingly happening. But I think there's a few different things to keep in mind. We need to keep talking about it. We do need to keep advocating. We need to keep highlighting the research questions that qualitative research can answer and how important those are. And we can think about that even in relation to COVID and some of the responses that have happened. We can see the data that shows us what the number of people getting vaccinated are, but we don't know why and what the hesitancy is unless we go out and ask that. And so really being able to demonstrate that. But on the flip side, there are journals which are asked, their purpose is very clinical, their purpose is very quantitative, and sometimes I think we just have to accept that's not going to be the place where they're going to publish qual, and that's okay. And so, there are now more journals that publish qual, there are qual-specific journals, and so there is room for us to get our work known.
A lot of the lessons and points that you spoke about today, were they things that you learned along the way, or were they things that were told to you, or did you have to kind of learn them and figure them out yourself? So
I am one of the few qualitative researchers, or when I first started post-PhD, one of the few qualitative researchers in a school of epidemiologists and, very clinical group, which is amazing, but it was a lot of the questions that I was getting from other researchers in my school, PhD students. It's one of the things that I get asked about. I run a qualitative short course, and I have been since 2014, and there's some of the key questions that come through. And I think they're an indication of the complexity and how much we need to do training in this space. But I learned so much of this by trial and error and made lots of mistakes along the way. And I look back on some of the work that I put out earlier, and it's embarrassing, but that's okay. We learn from it. And I'm going to look back in 10 years' time on the work I'm doing now and be like, what were you thinking? But I think we need to be gentle with ourselves and say we're always learning with qual research and any type of research, and that's always a good thing.
And I think that's such a valuable lesson for all things in life, that we're constantly learning and nothing will ever be perfect. Another question that we have.
Emma, maybe if we just, before we move off that, I'd probably add that most of the people that are sort of supervising research, particularly in the surgical field, are really only have exposure to quantitative. Their whole, any research they've done has been quantitative. The journals they read only have quantitative research in them. And so you're basically trying to tell someone who's colorblind what green looks like. And so it's much as a responsibility for us to educate those supervisors as to encourage the junior medical students or trainees to do qual research. We've got to educate the people that are potentially going to be supervising them as well.
Very good point. Yeah.
Ian, do you think that qualitative research will continue to grow in orthopedics specifically?
Yeah, it's got a big place because, as Dash made really clear in her talk, it's about answering the why. Why do things happen? We can measure, we've got a great joint registry. We can measure outcomes. We can do all those sort of things. But often that'll not tell us why, one particular process works well and one doesn't. We do, or, why a procedure works better. So we do need qual research to actually get to the why, I think, a lot better. Otherwise, we're just guessing.
Very true. That's very true. Do you think, Ian, that doing research makes for a better clinician and vice versa?
Yeah, good question. I would say doing good research makes for a better clinician. I certainly have experienced many, or not been part of them, but heard about many research projects that really were just under tick a box. I've got to do a research. I'm going to do a case study on a left knee replacement, and that'll be my research project ticked. That I don't think that improves the surgeon at all. So I would prefer to see people do things that are useful to them and also have some, I think Peter Chung used this term earlier, but that impact, the idea of impact. So we should be encouraging that work and creating the paradigm that people work in that can actually produce the impact. So that's why we want to encourage collaboration. That's why we want to encourage multi-center trials and things like that.
Another question we had was for you, Ian. To what extent is the research component of the orthopedic training pathway modelled on other specialties, both non-surgical and surgical? Whereabouts do you get the guidance into changing the program and what it's going to look like in the future? Yeah,
so the research requirements that we used to have are pretty much what all the other surgical specialties have, and I think also things like emergency medicine as well. In that we required contribution to a project that got to the level of being publishable, sort of as a broad overview. So that project pathway, the first of the three options that I talked about. But and I said we've spent months doing this. We brought in lots of people. Peter Chung was part of this as well, to look at what actually do we want to achieve out of a research project during training? What are the outcomes that we want? And then we design backward from that. And so that's why we've come up with those three separate things to try and, fit. Different trainees will have different desires during their training. So it's trying to fit in with that as well. What are the other surgical programs doing? I just looked up the GSA yesterday. They still have a project pathway. General Surgeons Australia, they still have a project pathway. So most of them are still just on that simple project type requirement. But I think they will eventually come along the way we're talking as well.
Okay, thank you. A question from Elise. Ian, you mentioned good research habits. What are one or two top research habits for qualitative researchers and clinicians?
Well, it kind of goes to both of us, doesn't it? Top research habits for qualitative. Wow. I think Peter and Michelle touched on this in their talk earlier on this morning of having something that interests you, so having a research topic that actually is something that you're interested in. Probably most important thing. And the habits are, regular communication. I think these were all covered earlier on this morning as well. Regular communication, common goals, shared mental models of where the research is going. Specifically about qual, I think Dash is probably much better to answer that side of things.
Sure. I think one of the things that can happen with qual, and I saw also a question around, where do you start with your data analysis? It's really easy when you're doing qualitative research because so much of it will produce lots and lots of transcripts and data to get lost. And so good research habits in qualitative research is, yes, start from a place of curiosity, but articulate what your research questions are and use that to guide you throughout the process so that you don't drown. Like they're signposting things for your data collection, for your data analysis, for your publications. Yes, things might evolve, but I think the real importance of understanding what are you trying to actually answer? What is your research question? And keep coming back and checking that you're putting things into place to actually address that. Because, I will review things and people will say, this was my research question, and they show me their interview guide, and you can have more than one research question, but they'll show me their interview guide, and their interview guide won't actually address their research question. Like there's just a disconnect. And so I think you're overly complicating things if you're not guided right throughout by your research questions.
That's very good advice.
Another paper that came to mind that's really useful in that sort of early part of the constructing of your research project is by Lorelei Lingard and Chris Watling, and it's called the Problem Gap Hook Heuristic. And it's a great paper. Recommend everyone read it, but it really helps you define what your research question is by deciding what problem are you going to address, and then seeing what's out there in the literature and then what's not there in the literature. And it really does help you to just really clarify where that particular project that you're working on is going to go.
That's all very good tips. I guess looking at the other end, one of our audience members has asked, when thinking about writing a qual or mixed methods manuscript, where do you start to find a suitable journal, particularly when thinking about the success of going through peer review?
So one of the things that was so valuable, which I didn't appreciate at the time when I was doing my PhD, was the time to read, like the time to read other people's work and emerging literature. I feel like I don't have as much time to do that because I work across too many projects sometimes. But when you're reading what's out there, you get a sense of where people are publishing in a similar space. You get a sense of where the leaders are. I sign up to Google Scholar alerts for particular people, and then I get a sense of where they're publishing. And if they're people like Trisha Greenhalgh is amazing. I don't know how many of you know Trisha, but she is prolific on Twitter and she's an amazing prolific publisher. And so I can see where she's publishing, and I'm aspiring to kind of publish in similar journals. I think you've got to be realistic because sometimes word counts are the bane of a qualitative researcher. We want to be able to show quotes to demonstrate our work, and some clinical journals will say you've got 1,200 words, and that's sometimes just not going to make an easy manuscript to write. So I do tend to publish in health services journals that are more general as opposed to a specific clinical journal. Because I do a lot around patient experience and patient understanding, there are more patient-focused journals like The Patient or Health Expectations or those types of journals. And then I'll occasionally publish a very tightly scoped out paper into clinical journals that are answering a why question, like Ian was saying, that is very relevant to clinical practice. And so you frame that very tightly and you put that in.
And I'd say that the clinical journals are coming around a bit more to publishing mixed methods and also some qual papers as well.
Yeah.
So there have been some mixed method papers published in the Journal of Bone and Joint Surgery, for example. So there's certainly there's an understanding that they probably do need to move into that space a bit more. And from my particular point of view, there's a whole body of surgical education journals that, if you're doing a surgical education research project, that, they all have different facets. And unlike Dash, where do the people that I like to read, where do they publish? They're the ones that's the journal that I want to go and publish in.
All great advice, all great advice. There was a question here, a little bit about the training program. Why are Masters of Public Health or Health Science not eligible for points under the CV component of the AOA 21 selection?
Yeah, okay. So yeah, we're talking right back to going to selection process. Now, I did do a webinar on this for Opus a little while ago, a month or two ago, and I think that's probably still going to be available. So that will be one thing to go and look at. But just briefly, we looked at the performance of trainees on the training program for many years, and then looked at their CV scores and how they correlated. And what we had was the people that were not performing well on the training program had the higher CV score. So it was an inverse correlation. And it's probably because a higher CV score was compensating for lower scores in the other domains that we were selecting in. So we've made a deliberate, and this was also backed up by a PhD by Zaida Oldfeld at the RACS, who looked at it across surgery in general, and that same finding came out. And so what we decided was that rather than try and encourage lots and lots of high degrees, masters, PhDs, is we would depower those achievements so that it wasn't, if you couldn't get on any other way apart from getting a PhD. So the idea was to try and not use academic excellence as a selection tool so much as encourage it during training. Because we have in the past had people that got selected because they had a PhD and they were not good trainers or did not turn out to be great surgeons. I won't mention any names, I promise. But yeah, that's the reasoning behind it. And so yeah, there is a small allocation of points for a higher degree, but it really, the CV, it's easy to achieve the maximum number of points in the CV in lots of different ways. We're not penalising people that have done higher degrees. We're just not over rewarding it, I guess.
Yeah. I guess this is kind of on a similar path. One of our audience members, Anne, has asked, Ian, interested to hear your thoughts on how important it is for trainees to actually do research rather than just learning critical appraisal evidence-based practices, to have research ethos and be good evaluators and users of research. Do you think it makes a big difference?
Yeah, well, yeah, it's a really good question. And I think that's why we developed the coursework pathway, because the main aim for us was to have people that are research literate rather than actually become researchers. And so the aim of that is to have people to be able to understand it. It certainly will be useful if they do go into more research. But we wanted to, the main goal was to have people that were able to understand the journal articles that would be influencing their practice for the next 30 or 40 years. So that's why we've done that. Participation in research, I think we talked about this before. I think participating in good research is very useful. But presenting case series of 3 left toe nail operations is not going to get anyone anywhere.
I guess a question to the both of you. Do you think one of the ways that we could try and promote qualitative research would be to put a focus on qualitative training for supervisors of higher degrees for medical students? Is that one way that we could get more exposure and more experience to the students?
I think so. I mean, I really do appreciate that supervisors tend to also supervise in areas they're comfortable and areas they've been trained in, and they supervise in the type of research questions they're asking, and it is a big paradigm shift. I cannot underestimate the value it has had for me in my career as a non-clinician who moved from quant research into qual research to work alongside people like Peter Chung, Michelle Dowsey, and people on this Opus team to bring some of that qual component in. And so I think there's other ways that we can improve the uptake and capacity building and partnering with people who are trained in qualitative research in co-supervision, and those types of approaches might be a win-win for everyone. And so I wouldn't necessarily discount that, because I do think it's really hard to get busy people to keep getting to training, and qual research is something that requires quite a lot of training and reflection and practice, is what I'd say.
Yeah, I think the key word there is partnering. Rather than try and teach someone to be a qual researcher supervisor, just have two supervisors, have partners that each use their own expertise. And we do that for the master's program for surgical education. We often will pair supervisors if there is a qual component to the research work. It works really well.
Definitely using people's skills and strengths, bringing that to a team is really good. Yeah. I guess
Aces in their places. That's like the catch cry. Aces in their places. Just, you know, it helps everyone's mental health.
Yeah. Important also, yes. I guess just to close off this session, what would be your biggest piece of advice to students who are about to begin research, embark on their research journey, either within their clinician training or in other avenues? What would be your biggest advice for them today listening? Big question.
I would say make sure you make time for it. I think one of the biggest causes of failure is trying to jam it in around the edges. You know, and you've got really important family life commitments. You've got to do the working hours for the current job you're in. You've got to do the university hours if you're doing study. But I think it's a really important thing to actually dedicate chunks of the day or parts of the week that you're actually going to work on that particular project rather than trying to squeeze it in at 10 p.m. at night.
I would agree with that. And my second thing would be choose your supervisors carefully. It's actually less about the project and more about the people you're working with and the team environment you're in and how much support and nurturing is going to happen there. It can be an isolating experience. It can be experience with lots of ups and downs, and you want to make sure you've got good supervision to help you throughout that process.
Both great advice. Thank you both for joining us today. We really appreciated all the extremely comprehensive presentations and the skills that we've learned. So we do really appreciate it. Thank you so much, Dash and Ian.
Thank you.
Thanks, Dash. See ya.
Bye.
Yeah, great. So we're just about 12:30, a couple of minutes early. So we're going to go to lunch now. Goes for an hour. So log on just a couple of minutes before 1:30. And also